Highlights on basic pediatric ventilation during the coronavirus pandemic. Stage 1. Make sure the minimal number of staff members is in the room with the most senior physician performing the intubation and one additional person assisting them. Stage 2. Make sure you are fully protected. Gloves, visor, hat, gown, and N95 mask. Stage 3. Make sure you have all the available equipment. A 100% oxygen non-rebreather mask, a video laryngoscope as a primary option, a regular laryngoscope as a secondary option, an ET tube, the correct size for the patient, and an LMA if the intubation is unsuccessful. In addition, we should have a suction catheter and device, and a ventilator with an ET CO2 sensor on hand. In addition, we should have a bag valve mask with a filter attached, but this should only be a last resort since using it might result in an aerosol being dispersed into the room. In addition, we should have rapid sequence induction medication available. Ketamine, rocuronium, and atropine may be considered in pediatric patients, and an empty syringe in order to inflate the ET tube balloon. Once the patient has been pre-oxygenated for 3 to 5 minutes, we may begin the rapid sequence induction. It should take 30 to 60 seconds for the medication to take effect and make the patient fully unconscious. Once this has been achieved, we may begin the intubation process using the video laryngoscope as previously stated. The reason we use a video laryngoscope is in order to keep our face as far away from the patient's mouth as possible, thus by reducing the chance of infection. Once the ET tube has been fully inserted, we should immediately inflate the balloon, transfer the filter from the bag valve mask to the ventilator, remove the guide from the ET tube carefully and immediately cover the end of the ET tube, and connect the ventilator through the viral filter to the ET tube as quickly as possible.
Key points regarding using Ambu mask ventilation in pediatric patients with confirmed or suspected coronavirus infection. As a rule, it's better to avoid Ambu bagging these patients. The Ambu mask is an open system. Aerosol is generated from the area between the patient and the mask, as the mask is not completely sealing the face, and from the expiration area of the Ambu itself, as it is again an open system. If you have to use Ambu mask ventilation, make sure you have a filter between the mask and the bag. Try to fit the mask as much as you can on the patient's face to prevent aerosols, or even better, do a two-person technique with one person fitting the mask as best as possibly can, and the other person will be bagging the patient. Using a ventilator in pediatric patients who are suspected or confirmed to have coronavirus infection. Several very important key points. Our main preference is to use a ventilator that has a double arm, a C-arm, 2 tubes that are connected to the ventilator. You must pay attention that you have bacterial filters on both arms, on the inspiratory limb and on the expiratory limb. And of course, you'll need a bacterial filter, and it's also an HME filter connected to the patient itself at the end of the Y. After the filter, you can put on your Untitled CO2 sensor. When coming to ventilate the patient, it's preferable in the adult literature to work with volume ventilation. However, the majority of pediatric ventilators work and open immediately on pressure ventilation. So when you open on pressure ventilation, make sure please that the PEP, the positive and expiratory pressure, will be set at least on 10, and the positive inspiratory pressure will be set at least on 25. These patients require high pressures in order to oxygenate. Of course, 100% oxygen.